So, Will Pierce, I'm so excited to talk today about Medicare. But before we dive into all that stuff, all that mess, I'd love to learn more about you. You were introduced to me by Nina Morjani, who's a Measure Twice Planners member, very generous member. And she said, hey, I talked with this guy, Will. I kind of met him through social media and he helped me out with some Medicare questions. You've got to talk to him and you've got to get him on a niche expert presentation. Looking at you, you don't look like somebody who's been on Medicare before. And
Correct.
I'm
Yep.
guessing most of the clients that you might work with in terms of Medicare might say, like, oh, you look just like my grandson, or you look just like you remind me of my son. So before we dive into the actual product of Medicare and the insurance and all that, I'd love to know, how did somebody like you get interested in something like Medicare?
Yeah, you're not wrong, Cody. I get those comments all the time. You look just like my grandson Jimmy, or oh my gosh, my grandson also played baseball growing up, or what have you. I get those comments all the time from clients that I'm sitting across the kitchen table with and talking with. But really, I got my start years ago actually helping my own dad when he was aging into Medicare when he decided to retire. The community we lived in, he didn't have any of the agents in town that he felt comfortable working with, that he really felt like had his best interests at heart when
Mm,
it came to his insurance options and what the long term of his coverage needed to be. And so here I am working in retail, every day at my age. And then I make the transition. I get licensed, I sit through the testing, I do all that. So my own parents are really my first foray into the Medicare insurance world and insurance in general, really no prior experience coming in, and just absolutely fell in love with the advising aspect of it, really getting to sit down and sit with what do you need. The thing I'm most proud of with the agency is that no two people get the exact same presentation, because no two
mm,
people have the exact same needs. Even between a husband and a wife, you're going to have different needs, different health outcomes that you're really trying to shoot for. And so I'm really proud of that with the agency, but it's been so much fun over the years, all the stories I've heard, all the people I've gotten to meet. So I'm really thankful for my dad, without really realizing he
mm.
was doing it, kind of pushing me into this career path.
I love it. So along the way, we're going to learn about you as you learn about Medicare. So the first resource I want to mention here is called the Medicare and You Handbook. This comes out every year. This is the official U.S. government Medicare handbook. So you don't have to worry about this being like something somebody reads and tries to sell them a reverse mortgage product or something like that. But I want to show you that, again, we're going to share this PDF in the link below the video. But Medicare and You is a great handbook for the fundamentals. Again, Will knows kind of beyond the basics here, but this is a nice fundamental way for everybody, including, you as a planner, or also the clients that you're serving, to learn more about the basics of Medicare. Again, we get really confused with, like, there's numbers involved, there's letters
Mhm.
involved, A, B, D, C, like this, what, like C is like a bundle, and like we get really confusing really fast. So before we dive into beyond the basics, let's start with the fundamentals. So could you describe effectively what is quote unquote original Medicare and what does that mean?
You're not wrong I always refer to this for people as alphabet soup. You're going to hear all sorts of abbreviations, and we'll talk about even more abbreviations later in case, A, B, C, D is not quite enough for everyone. But Medicare Part A, and the biggest questions that I get with what's called original Medicare, which is going to be your Medicare Part A and your Medicare Part B, the biggest questions I get with that is it free? What does it cover? And what does it do for me? And, the answer is Medicare Part A is usually, in italics there, free for people that get it. If you worked your 40 quarters, you'll qualify for what they call premium free Part A. And then Medicare Part B is going to have a premium to it. That premium is going to be dependent, as we'll talk later, on your adjusted gross income from 2 years ago. That's always what trips people up. It's not based on last year. It's actually 2 years ago, and there's some ways to work that as well. But your Part B is not going to be free, and there is going to be an associated premium with it. And then, what does original Medicare not cover? I think Cody summed it up great. And one time I was talking with him that it doesn't cover the things that decline as we age. That's going to be your vision, your dental, and then affiliated long-term care, home care, things of that nature are the biggest caveats that original Medicare doesn't cover. And of course, as you see and as you may know, with Part B, there is a 20% coinsurance with a lot of things like that. So Medicare is covering 80%, but there's still a 20% associated coinsurance for beneficiaries when they're using those benefits.
And as we talk later about this thing called Medigap supplemental plans, Is that 20% considered the gap, or is that another term?
That is considered the gap. So when people refer to a Medicare supplement as a Medigap, the implication is that it fills the gaps of the original Part B coverage. Medicare supplements, as we'll cover later, don't cover dental and vision, but they are covering the gaps of just that Part B medical insurance
Hmm.
coverage.
So if we're comparing, a lot of people are going to think about Medicare compared to the, especially workplace coverage. And I wonder, does Part B, does that have like an out-of-pocket maximum, like some like traditional health insurance?
I think that's a great comparison because a lot of people think when they look at what Medicare is covering and they think, oh my goodness, there used to be a really big wave when people turned 65 when they aged in. They would go get all sorts of things done because they actually realized that Medicare covered a lot more than their traditional group health plans did. And even if it maybe didn't feel as strong, premiums might be a lot lower for them. I mean, I know I've talked with people that were paying a little over $1,000 a month for their group insurance and then not seeing the same associated just monthly premiums on the Medicare side. So Medicare doesn't have, on Medicare supplement or on original Medicare, you don't have to think about annual out-of-pocket maxes. You don't have to worry about things of that nature. So it's a lot different mindset for people when they're leaving their group insurances, when they have to think about where am I at in my annual deductible? What's my copay? What's my co-insurance? Okay, well, where does that compare to my out-of-pocket max? I might have a $1,500 deductible, but a $10,000 out-of-pocket max on the policy. So it really is a lot different of a structure. And that's why a lot of people, when they turn 65, they go get a ton of things done. They go get all these checkups done. They get all these screenings because it's a way different cost benefit analysis that they're looking at from their group plans.
Yeah, absolutely. It's one of those things where it's, again, there's that, anxiety is the fear of future uncertainty. So, anytime you learn something new, it's scary, which is why we talk about, the fundamentals first. I have an example, W-2. This is a really great way to maybe start the conversation with clients who are moving from working to going on Medicare. A lot of employees don't realize what the cost of their group coverage is. You can see that Form W-2 and box 12, code DD, is the combined employee plus employer premiums for health insurance. And you can see the employer themselves they're probably paying like over $20,000 for this coverage. Employees truly need to understand the full form of compensation at their job. If you say, hey, I get paid $100,000, I was just offered a job for 110,000, I'm going to go change jobs. They might not realize that that new job they're going to doesn't, pay $20,000 toward their health coverage like this job did.
Absolutely. They may have a lower amount that they pay towards that health insurance. And they may also, there's a lot of other considerations, such as what's the retirement program like? How much will they match up to? Because usually employers that would cap at a 2% match. Then you've got others out there like, we'll go up to 5. Like we want employees to dump money into this plan. And so there's so many more considerations on the table than just what is your actual hourly pay. I was always a benefits nerd, hence why I'm still in this industry. And so, it's really a full picture compensation package that people need to be weighing and need to be considering.
Yeah, you really need to look beyond your base salary in terms of compensation. Again, this is why I love having these conversations because we get to kind of go in and out of the original the original subject here. Original Medicare, we talk about A and B. Does original Medicare also include Part D?
So I don't consider Part D as part of original Medicare. It is a vital part of everyone's coverage. I advise everyone to have drug coverage, and we'll talk about why it's so important later. But original Medicare traditionally is just your A and B. You just have to enroll in both A and B, but D is a different consideration. And like we talked about with Part C as being kind of more of a bundle approach, Part C also then includes your Part D drug coverage, whereas a Medigap plan or a Medicare supplement would not. So original Medicare, the way I present it, the way I discuss it, is just your A and your B. And then we'll talk about the other avenues of coverage as different aspects.
Before we dive into fun case studies of what it looks like in real life, I do want to show, kind of what it looks like after the fact. So this is an example of it's called a SSA 1099. So this is a tax form they're going to receive to show that really the two things that really matter from a tax filing perspective are box 5, their net taxable, not necessarily taxable, but net benefits from Social Security. Again, you'll see that there's those thresholds of 0%, 50%, 85% included in gross income. But also, this is really interesting, is box 6 is voluntary federal income tax withheld. You see, this client did not withhold any taxes from Social Security. First of all, if somebody's only form of income in retirement is Social Security, they will not owe any taxes. So they should not have their taxes withheld unless they want to tip the IRS. But I will will mention here that let's say one spouse is still working, in their highest earning years before they've switched to Medicare. And in this example, this spouse only has Social Security. They might go, oh, well, my income went down, so I'm not going to withhold any taxes. But they might not realize that this is being stacked. Probably most likely 85% of this amount in box five is going to be included in gross income. But let's say Susan Sampleton, her Social Security benefits are 7818, and let's say her spouse is still working, making good money, their income is high enough that 85% of that is going to be included in gross income. So 6645 and 30 cents would be included in gross income. And let's say that, again, because of their combined household income is going to be taxed, let's say in the marginal 24% bracket. This person, they withheld nothing here, but they might be surprised when they owe an additional $1,600 on their federal income taxes. A lot of fun screen sharing there, but I'm excited to now jump into some little case studies here. Let's kind of assume for a minute that somebody, they're 64 years old. They're like, hey, I'm turning 65 4 months from now. Again, I'm throwing out 4 months kind of as a little hint here, not 3 months, but 4 months. And
Yep.
they come to you and say, again, I guess you first educate them probably on the fundamentals of what's happening. What does it actually look like in terms of order of operations of I'm leaving my employer, I'm going to fully
Yep.
retire
Mhm.
at 65, and I've got a few months till that happens.
Yeah, absolutely. Great question. So, when we're looking at someone that has decided to make the jump and they are retiring right at 65, because there's different considerations when you're working past 65, or even if you want to continue to work, but maybe you work at a smaller company or self employed. So, there's so many different considerations. But taking someone that's 4 months out from 65 and they know they're retiring, they know they're taking the step out and leaving, we start gathering a lot of paperwork for them, which is nobody's favorite job. And it's definitely not my favorite aspect of the job here either. But we're looking at, I need all the information from their HR benefits manager. I need to know what were their dates of coverage on that
Mm,
plan. When did it start? What's the actual official end date that's been put in and been
mm,
posted, if they have that yet? And then making sure they have copies of their credible coverage information as well. I always want to make sure people have that information handy, because that credible coverage determination is so important to any penalty avoidance that we could ever possibly run into, that you've always had credible coverage from your job. But we've got then a special enrollment to get into your B once you know that you're leaving. That is a 6-month window that you have from that. And then you also have your initial enrollment period. And this initial enrollment period is also very crucial to any elections you may make into what type of insurance you want to have, whether that's a Medigap in a Part D or a Medicare Advantage / Part C plan. That initial enrollment window is going to be a 7-month time frame. 3 months before you turn 65, the month of, and then 3 months after. So it's always been kind of a goofy layout in my mind.
mm,
Why not just make it a clean 6 months or
right.
some cleaner number? But we're not working with that here. We're working with 7 months. So you get 3 months before, the month of, and then 3 months after. So this person, 4 months before they turn 65, is just a touch early, but I love those type of clients. I'd rather someone come ahead of the ball game and prepared and know what they want to do. And I can say, I love so much that you're prepared. Here's the forms you're going to need to file. Here's all the information, the questions Social Security might ask you. Hold on to it for a month, and then we can put everything in for you. So that 4 month before you turn 65 is a great time to start the prep work, a great time to find the agent that you want to work with and start asking them the questions that you may have, because that gives you a month to kind of get your feet under you and feel
Mm,
comfortable with your decision before you have to start the process. I've had people that they come to me early and they start looking at it and they're like, well, maybe I'm actually going to stay at working just a little bit longer. Maybe, it's maybe I'll just retire in the new year and I want to kind of finish out the last bit of this calendar year. So there are times where people think they've made their minds up and then they start looking at the full picture, and there's just something like, oh, well, maybe I'll retire the same time as my spouse, which is going to be next March or what have you. So there's a lot of considerations there, but 4 months, the earlier is always the better if you feel strong and confident in your decision. But 3 months before, the month you turn 65, and then 3 months after is going to be the pivotal window to really get everything in and started.
I love that you consider their coverage ending date, because that's something that's, I mean, most clients I work with, they kind of on average, it says, your health coverage ends at the end of the month that you terminate employment. But there's a big little like kind of caveat there that a lot of people don't realize when the actual termination is. So I work with clients where they have like some type of like deferred compensation, or they're kind of paid out a few months after they actually like, leave the office. So it's
Mhm.
really important that, again, first of all, you have to make sure there's no gap in coverage, but you also want to make sure that you're not paying for two at the same time unnecessarily, like too early. We also have sometimes employers and employees contribute to an HSA. And we're going to dive a little bit more into the HSA and some other like little fun characteristics around that. But it also makes me think one really good thing about HSA contributions is that you have until April 15th of the following year to
Yeah.
actually maximize them. So I think, some people they'll just go ahead and say, let's just stop. Like if we know we're about to, retire soon, let's go ahead and stop our HSA contributions. We can't necessarily control the employer contributions, but let's go ahead and stop ours just to make sure we don't like make excess contributions. And if we find out that we actually were under the limit by the end of the year, we'll still have until April 15th to max it out for, again, but keep in mind, again, I know we'll talk about this later, but the HSA, you can only contribute to an HSA for the months that you're not covered by Medicare, which is, kind of a convoluted sentence there. But effectively, you can only contribute to an HSA based, pro rata for the months that you're actually covered by a high deductible health plan and not covered by any part of Medicare. So
Yep.
I know I jumped the gun a little bit there because I love HSAs, and we'll discuss a little bit more. Now let's think about a little bit about case studies where somebody they're turning 65, but they still plan on working for a few more
Yeah.
years with group coverage. And let's say for this example that they work at a large employer with a lot of employees covered. What might that look like?
Yeah, so Cody makes a great point, a great caveat on a large employer with a lot of individuals covered. The biggest number to weigh that consideration when we look at, because the discussion surrounds who pays first. And I'm air quoting that because that's also the term that Medicare likes to use is your who pays first decision. If you work at a small company and that is a sub 20 people covered employee, then you need to look at Medicare is most likely going to be your primary coverage once you do turn 65, which means you will need to enroll in it if you want them to pick up any portion as a primary insurer. And if it were me, I certainly would want them to pick up that portion of the primary insurer. But if you work at a large company that's over that 20 threshold, Medicare is most likely going to be secondary. And then it's a way different consideration for individuals. When you look at that, so your group insurance is going to pay first, and then whatever is remaining will kick over to a secondary insurer if you have one, and then they cover and they will pay from there what they would agree to pay. Now, the consideration comes, do I still pick up A? Do I still pick up B? If you qualify for premium free part A, I absolutely would pick it up. It's not costing you anything additional to take it and to sit on it from there. Now, discussion always comes around part B, and that is a little bit up to the individual. Like we talked about earlier, Cody, people don't realize how expensive their health insurance at their job place is. For some people, an extra $300 a month of insurance coverage is just not worth to cut the teeth on. And that's what I see a lot of anymore. I see a lot of people when they continue working and they're at a large employer, they pick up premium free part A, and then we hold off on the B until they retire. And the beauty of the way the system works is that when you do retire, you still get an election into your Part B. So you're not having any issues, you're not causing any enrollment penalties because you've been covered by a large group health plan the entire time, causing your Medicare to be secondary. The people that work at smaller companies with sub 20 really need to look at picking it up and not delaying that Part B coverage, which for some people actually pushes them to retire earlier than they thought they wanted to, because it's like, I have to have both. I have to have Medicare because they're primary and they're first. And then I need to have my group insurance at the same time just to make sure all bases are covered. Oh my God, I don't want to pay all that money. I'm just going to retire. It's fine. I've got enough in the nest egg. But we also see some employers as well that will allow people to continue to work and then not have to take out the group insurance because they have a primary insurer. So there's all sorts of kind of, niche carve outs and caveats within this. But if you work at a large company, I'd take out premium free part A as long as you qualify for it. And then if you're satisfied with your group coverage, I would delay part B until you choose to retire. And then you get everything started at that same time and have a start date for it.
Yeah, that's great. So a lot of this is like this is something you have to do. Like this is a proactive
Mhm.
decision. And
Yeah.
like Medicare is not just going to like say, "Hey, you're 65, you suddenly get it." Unless there's a little caveat, right? So if you're receiving Social Security benefits already,
Mhm.
So like when you get to 65, they're automatically going to enroll you and they're going to send you that red, white, and blue card in the mail. If you end up receiving that card, but you actually didn't want to start Part B yet, what do you do?
So you have to call Social Security, which is anymore. The phone lines are usually reasonably long waits, or make an appointment at your local office. I personally like making appointments at the local office. I like talking to people face to face. I always think that's a better way to operate when you can. If you're not in a spot where you can do that, you need to call Social Security and tell them, I actually want to delay my Part B. And really, you need to catch it before that start. Like if you get a letter in the mail and it says your start date is 4/1, Cody and I are sitting here talking on March 12th, I'd be getting on the phone pretty quickly and telling them I do not want this Part B to start, because it can take a little time for the system to catch up and the system to mark that. So if you get that information in the mail and you're like, I really did not want this to start, this is an error, you need to call Social Security and tell them I want to delay my Part B for XYZ reasons, whatever your situation may be. But it needs to be a phone call to them. You need to get that process started as soon as possible so that it does not go into effect and you don't have to deal with any premiums that maybe you're going to get credited and refunded back. And then you've got a whole mess to untangle and unwind. So the earlier you can get on the phone with Social Security, the better for all parties.
Now that we've talked about kind of the original Medicare enrolling, you've retired or didn't retire and you're enrolling, now let's jump a little bit to that gap. So we talked about the 20% co-insurance that after you've hit your deductible for Medicare, what's the difference between a Medicare Part B deductible and a deductible on like a group plan?
So usually the difference is that it's a heck of a lot smaller. So when we look at the Medigap plan letters these days, Plan G is the most common one that people are enrolling in. Plan N is picking up a little bit of interest, but Plan G is still by far the biggest. That does still have the Part B deductible to it. For 2025, it's $257. That number fluctuates a little bit every year, usually goes up a little bit every year, but not by a tremendous dollar amount. So but when I think about a deductible on a group insurance plan that I've seen, I mean, $1,500, 2,000, 5,000 for some is not uncommon. So you tell someone you're going from a $1,500 deductible to 257 on their Medicare, on their Plan G plan, that's it. Yeah. The big caveat and the big asterisk I always put on that is Medicare approved and what Medicare covers. There's all sorts of things we can get into as far as billing codes, ICD-10 codes, things of that nature that may cause something to not be covered and not be approved by Medicare. All sorts of ways to get that reversed and re-looked at with your providers as well. But as long as it's covered by Medicare and you've met your deductible, you should really see minimal out-of-pocket exposure and out-of-pocket expenditure on a Medigap plan. Almost everything with Medicare operates on a calendar year basis. So if you go in December, meet your deductible, but then you have to go back in January, you may have to meet it kind of in a back-to-back month span there, but it'll reset every calendar year. And then for the rest of that calendar year, you're pretty well taken care of.
There's original Medicare, and then there's this big decision people are having to make. And maybe we can kind of flip this around a little bit. So a lot of people, the only thing they've learned about Medicare is by seeing a commercial on TV that says, hey, you're about to turn 65. You should sign up for Medicare Advantage and it's free to you. And it also includes things like a gym membership and, maybe dental, maybe vision. Maybe we can start with the idea of what is Medicare Advantage and how does that play a role and compare and contrast with original Medicare?
Yeah, so Medicare Advantage, also known as Part C with individuals, is a bundled style coverage that will usually include your drug coverage, your primary health benefits, and then usually, not always, dental and sometimes vision benefits. And then there's extras like gym memberships and things of that nature built in. They are usually low or no premium. Medicare Advantage plans are filed and built by the carriers with CMS on a county basis. So every plan has to be built and filed in that county that they want to provide that plan in. And so for me, located in Iowa here in Polk County, a plan has to file and be approved by CMS to operate in Polk County, and then any other counties in that state of Iowa, they want to file that plan in. But it functions a lot like a group insurance plan as far as you have a lot of copays and you have a lot of co-insurances to them. There's also an out-of-pocket max on these plans as well that will vary and either increase or decrease every year by CMS filings, but you'll have it. So just for an example, you may have a zero premium plan, but you've got a $4,000 out-of-pocket max on that plan. Copays, like your $20 copay when you go to the doctor, does not count towards that $4,000 out of pocket max.
Mm.
So, absolute worst case scenario, you may be on the hook for $4,000, but you're paying no premium. These plans are absolutely a fit for some individuals. And the way that I approach it is, what are you wanting to get out of your retirement coverage? When I have someone that comes to me and they tell me, I spend half of the year in Arizona, I'm a snowbird, I don't want to deal with winter in any capacity in this state. That's awesome. Absolutely. Medicare Advantage plans operate on a network basis. You have to
Mm.
see a doctor that is in that provider's network and in that plan's network. There is a little bit of national network reciprocity where I live in Iowa, but I can find in network care in other states. You got to call the carrier or me if I'm your agent, and I can help you find someone that may be in network in that area. But again, can't just pop in and kind of see whoever you want whenever you want. There may be referrals involved for specialists as well if you're needing to get knee surgery done or need to go see an ENT doctor for something. You may have to get a referral from your primary care physician in order to do
Mm.
that. So they have networks you have to adhere to if you want to get the in-network coverage. If you go out of network, expect to pay higher cost shares and higher co-insurances on all of your care as well. And some plans even have a higher out-of-pocket max if you go out of network as well. So there's a
Mhm.
lot of considerations with Medicare Advantage plans. Can they be a fit for some individuals? Absolutely. I'm about split with my clientele base. I'm about half Medicare supplements and about half MA because I truly believe that there is something for everyone out there. I even have a lot of individuals that I jokingly call them the healthy and the wealthy. They have done really well over the course of their work and they're retiring and they're very healthy individuals. And they're like, I don't plan to ever go to the doctor unless I'm dang near on death's door. I don't want to have to pay a premium for something I'm not planning to use. I'm already paying an IRMAA premium on my Part B. I just give me the zero premium option. I can eat $4,000 if I absolutely have to in worst case scenario. Like I'll take that. And then you've got the flip side of that for people that have done well, don't mind paying the premiums. They're like, I want to make sure that no matter what happens, I'm really going to see minimal, if any, out of pocket expenditures. And the biggest question with Medicare Advantage plans is, well, how can they afford to give me all of this stuff for zero premium? How can they afford to give me $2,000 in dental a year, plus pay for my gym membership to the local YMCA and all that? So
And pay for the celebrity on the television commercial. Yeah.
yes, yeah, absolutely. So the way that these plans are built and they work is that, say you pick a carrier, they will actually replace, in air quotes, your original Medicare as who handles that billing coordination for CMS. So they're actually taking that billing coordination off of the federal government's hands and doing all the coordinating themselves. And because they choose to do that, CMS gives them a set dollar amount per member on an annual basis. That dollar amount is built off of what they call star ratings. So it's a 1 to a 5 star system, 5 star being the highest rating a plan can achieve. That is done by kind of a convoluted system of member satisfaction, billing and claims data, and all of this. And carriers get these preset dollar amounts and they have to spend it. They
Mhm.
cannot just, if say getting $3,000, just use flat numbers and they're spending two, they can't just pocket that difference. They have to spend up to that
Mm.
dollar amount on a plan filing. You always see these charts, or I do online because I'm into sports. It's like you get $10, build your ideal sports
Right.
team. This player costs five, this one costs two,
Right.
what have you. Medicare Advantage plans are built very similar. They have all these
Mm.
benefits they have to weigh out, and each one has a different cost lever to it. Okay, well, if we add $2,000 in dental, that adds an extra $5 per member per month on a basis, just to use
Mm.
some flat math here. We have to factor that in. And so when you look at MA plans change every single year, you get what's called an annual notice of change. That'll tell you what your next plan year's benefits look like. That was based on the funding that they get from the federal government and how they have to allocate and kind of make the math work. But they get that funding from CMS because they take on the coordination of benefits and coordination of care and all the claims stuff for them. So as a way, almost as a thank you, they offload that to the carriers so they don't have to hire more staff, train more people. They just
Mm.
let the behemoths of the carriers handle it, and then they give them a flat dollar amount per member to do so.
Wow. I love that idea of kind of like if you choose the star quarterback, to throw the ball, you might not get the best wide receiver to actually
Yeah.
catch the ball. So you kind of have to
Yep.
weigh the pros and cons. And
Mhm.
the biggest thing that I hear from people, and you kind of mentioned it, is people say, well, I'm turning 65 and I feel like I'm really healthy right now.
Mhm.
So like I'm just going to do Medicare Advantage. So what are some possible like long-term considerations or I mean, I mostly hear kind of maybe the disadvantages of choosing Medicare
Sure.
Advantage to start.
What we see happen a lot is when you leave that plan, and if you want to go to a Medicare supplement plan, which is usually the jump people make, you have to health qualify for it. You have to go through a medical underwriting process. And that is usually on most health conditions a 2 year look back on what you've had going on and your medications as well. And carriers don't just look at your underwriting from a can you say no to all the questions. We're going to look at the medications and what story does that tell us? You're
Mm,
on these four medications. Well, usually, our actuaries say that when we see these four meds in combination with each other, it means that there's this condition going on. You may have
mm,
said no, but we may need to look into it further. And so those are fully underwritten. You have to health qualify for them. If you started out on a Medicare Advantage plan, say you've been on it for 3 years, you want to leave, you're like, I need to have a couple surgeries done. I don't want to deal with out-of-pocket max. I actually need, I want to make the jump over to a Medigap now. One of the questions on a lot of these is, have you been advised to have a surgery that you haven't had yet? And it's like, well, yeah, I have. And then they're likely not going to issue coverage because of that, because they are then weighing that
mm,
anticipated and planned claim into what they're having to cover. And so if you get on an MA plan to start, make sure that you're really taking an annual look at those. I evaluate
mm,
them with my clients every single year. Are you so happy with the coverage? You still want to stay with it? You got your annual notice of change. Let's take a look at what are you wanting to accomplish right now for 2026. What do you want that year to look like? Are you planning to travel more? Are you planning to do all these things more? So then we can actually plan ahead so they don't get caught in that rock and a hard place where
mm.
you're wanting to leave, but you just, from a health basis cannot leave. And then that always gets the question from individuals, well, how do Medicare supplements calculate their rates? How is this $150 a month number that I'm getting? How do they come up with that? So Medicare supplements are on a state by state filing basis. And that health pool, for lack of a better word, is then put into that state. So your Plan G, say a carrier has 1,000 members on that plan in the state. They then take those 1,000 members, how much premiums coming in, and how much are we paying out in claims. And actuaries use that to spit out a monthly premium that a 67-year-old in this zip code is going to pay. And then every year, you're going to take a rate increase with that as well, based on the health of that block with that carrier. So I've seen some instances where carriers are paying out more in claims than they're getting in premiums. That's going to lead to a pretty strong increase because, like we've seen in the housing market and property and casualty
Mhm.
this year, if they're paying out more in claims than they're getting in premiums, that's going to lead to insolvency. And insolvency is good for nobody in the insurance industry. Like, I don't want that. If you're covered by that carrier, you don't want them to go insolvent either. Like it's just bad for everyone. So those premium increases range from anywhere from 5 to 25%, I would say, on a rolling average. We're seeing really high ones right now, just from frankly what they're calling a COVID delay. 2, 3 years there where people didn't really go to the doctor. If you don't see a doctor for 2 years, what may have been a minor issue at that time is now a little more exacerbated and a little bit more expensive to treat. And so there's a big influx of health claims happening, leading to higher than normal rate increases right now. I think that'll eventually settle back down, but that's what we're seeing in the industry. And that's how those premiums are calculated because everyone just thinks, shake a magic 8 ball and all right, you get $200 a month. Okay, you get 100. Like it's actually built on a massive pool of claims within that state.
Yeah, I think we have to remember that insurance is a transfer of risk. It's an
Yeah.
actuarially calculated thing. It's not like they don't just
Yeah.
guess. Like this is actually like really smart people run really smart
Yeah.
numbers. I love that you say that Medicare isn't a like turn 65 and I make one decision for the rest of my life. Isn't there a period where underwriting isn't actually required from a health standpoint?
So there's a couple instances where you can get what's called a guaranteed issue period. You can get a guaranteed issue into Medicare supplement where they cannot ask you any health questions. Those biggest ones are the first 6 months after you pick up Part B, which is called your open enrollment window. They cannot ask you a single health question about anything going on in your life at that point.
Mm,
You could be diagnosed with cancer and they still have to issue you coverage. Other common guaranteed issue situations are if you move and you're on an MA plan or you move to an area where there's new health options available for you, you can get a guaranteed issue Medicare supplement then as well. And then there's one that's called Trial Right. And what trial right functions is as if you took a Medicare Advantage plan when you first turned 65, that's the big asterisk there. First turned 65, eligible for Medicare Part A, Part B, start dates all align. So 5/1/25, A, B, and MA start date all has to line up. Within the first full year, you want to go to a MedSup. You can do that without any health qualifications. But there are a ton of kind of carve outs and caveats to guaranteed issue situations that you can qualify for that would lead to no underwriting. But if someone's been on the plan for 2 to 3 years, haven't moved, there've really been no life changes other than I'm just ready to try something different. That's most likely in most instances going to lead to having to health qualify into it.
So it's not a set it and forget it, and there's an annual decision. But with that said, there is this window. You talk about that 6 month initial
Yeah.
window. That's a really careful consideration. And
Mhm.
we talked about Medicare Advantage, and is it kind of correct to say this is similar to like a PPO plan?
Yeah, I think the easiest way that for people that you kind of get that deer in the headlights look when I start explaining is like, okay, think about how your group plan worked, right? You had copays, you had coinsurances, and you had an out-of-pocket max, and you had to stick with the network, whether you realized it or not. They do still have networks. They function so similarly to group plans as far as like how it'll operate to the client. You'll go to the doctor, pay your $25 copay, and then you may get a bill in the mail for any applicable coinsurances that were not covered, just like you did on your group health insurance plan. And for some people, like, oh, okay, yeah, that was probably fine. So like, I hated that. I do not want that in any capacity. Please keep it away from me. And so there's both sides of the avenue, and you've got PPO plans, and then you've got HMO plans on the MA side. A PPO is going to have a broad network. It's going to have a lot more providers in that network. And then an HMO is going to be a very narrow network of care. They may only have 2 or 3 hospital systems in your area. Large metropolitan areas see a lot more HMOs because there's usually 2 or 3 providers in the area that have 5 hospital systems scattered throughout. That's like, okay, I'm going to partner with this one, and then we're going to partner with them for the HMO. But a PPO is going to have out of network care where an HMO won't. HMO, if you go out of network, we're going to be responsible for all of it. It won't be covered. A PPO will, and then you're going to have a larger provider of networks to visit and see
Hmm.
from.
And now going from Advantage, the other big
Yeah.
decision is supplemental plans. You briefly talked about Plan G, and we're like, wait, there's more letters. Kind of maybe step back a little bit. So the Medigap, again, filling that 20% coinsurance gap. What are supplemental plans?
Mhm.
Again, Plan G. I've always heard G for great or G for good. Like
Yeah.
that's kind of the Cadillac. I guess they'd call it a
Mhm.
supplemental plan. But what are supplemental plans, and how does that differ from Advantage? And I guess maybe you never asked 3 questions at once, but the last one here is thinking about the supplement, like how does somebody choose which one works
Yeah.
for them?
So I'm going to start with how does someone choose which one for them. So like you said, Cody, there's a couple different plan letters within. Plan F used to be the kind of original Cadillac back in the day,
Mhm.
but now they've set some guidelines in place of who can even enroll in a Plan F anymore. Now Plan G is kind of that flagship Medicare supplement. Biggest difference between what a Plan F and a Plan G covers is Plan F was back in the day covering that Part B deductible. Plan Gs don't, but they cover everything else with almost no out-of-pocket expenditures to the individual. So Plan G is now kind of the flagship, what everybody enrolls in. Plan N is the kind of second biggest one that we're seeing a lot of interest in. That one does have some small co-pays when you go to the doctor's office, and you still have the Part B deductible to it as well. But most individuals I see that are turning 65 are picking up a Plan G. Now, there's a lot of different considerations because there's a ton of carriers in the market. You've got smaller individuals that are maybe backed by other insurers that are rolling
Mm.
out their own Medicare supplement products. And then you've got kind of the behemoths, the names that we all recognize, United Healthcare, the Aetna, Humana, Mutual of Omaha, names like that that we all kind of just know in the industry. There's a ton of different weighting factors. They're all going to have different premiums for starters.
Mhm.
Medicare supplements are standardized in what they cover, but premiums are not standardized. It's based upon that carrier's
Mhm.
risk pool in the state. And so it's who do I pick? I've got a lot of clients that they want the brand name. They want the big
Mm.
carriers. They want to feel like, I know this
They can tell
carrier.
their friends who they have.
Yeah, I've got a United Healthcare ARP Medicare supplement. Oh, awesome. Perfect. That's what I want as well. And then you have something that's like, find me the cheapest one. I really don't care who it is. They have to cover what they have to cover. And that's the important caveat is what
Mm.
they cover is all standardized. So really what carrier you want to go with is completely up to the client and the individual. And when I look at, who are Medicare supplements really a good fit for, they're a good fit for individuals that don't mind paying a premium. They want consistency in what their coverage is going to look like. Med subs don't change other than your premiums every year. And then maybe they plan to travel
Mm.
quite a bit. And the beauty of why I add that one in is if you want to travel a lot, a Medicare supplement is going to be, as long as that doctor takes original Medicare, they're going to take your Medicare supplement. And so when I hear from them, well, my grandkids live in 3 different states. I travel to see them. We have a vacation home in Florida. When I started doing the math of trying to travel to 5 states and someone trying to find in-network Medicare Advantage care in 5 states throughout the course of a calendar year, a Medicare supplement may make more fit for that person as long as the premiums are comfortable for them, because you just find a provider that takes original Medicare. It's a lot less of just, I need to walk into an urgent care and I need to get this cough looked at. Absolutely. Find the nearest one. We don't have to check networks for that. And
Yeah.
so that's really a great fit for Medicare supplement clients, is either they want consistency and they don't mind premiums, or they really do plan to travel quite a
Mm.
bit.
And I love
Yeah.
that you're saying that Medicare Advantage is like kind of like the old school days, or like, when you're
Mhm.
working, where you had to kind of say, do you accept my specific plan? Whereas if
Yes.
you're on a supplemental plan, you can just say, do you accept Medicare?
Yeah, and the way that it works like that, because your doctor will bill Medicare, the Medicare kicks it over to the Med Sup to cover the
Mm.
rest. So
That's amazing.
they don't really even care. Like your doctor doesn't really care what Med Sup you have, because they're billing original Medicare, and the Medicare is crosswalking that data to the carrier, and they're handling it from there. So,
Oh,
do you
cool.
accept original Medicare and do you accept Medicare assignment? Yep, perfect. You can go see them without really any hiccups to your coverage and your care.
So you did talk about Plan G and Plan N as a
Mhm.
Nancy, and I do want to just mention that, I look at the chart here. It says the only difference there, Plan G, it says Part B excess charges. So what does
Mhm.
that mean, and is that important?
Yeah, so a Part B excess charge is going to be if someone does not accept Medicare assignment and they bill over and they bill an excess charge to coverage. That used to be a lot bigger issue than it is now. On the
Okay.
whole, less than 1% of providers out there are going to ever charge an excess charge. And even within that less than 1%, it really primarily was mental health providers and like
Hmm.
psychologists and psychiatrists that were billing that, because for a long time, they didn't accept Medicare assignment. All Medicare assignment is you're agreeing to charge Medicare approved rates for something. They weren't operating under that for a long time. Within the last few years, we've seen a big expansion of that. And really,
Yep.
that started during COVID, when people needed to work through stressors or needed to work through whatever they had going on, that they needed to go see a mental health provider. So Medicare assignment has expanded a lot within that. I have seen only a handful of excess charges in the almost 10 years I've been doing this. Like, it very
Wow.
rarely
Wow.
comes up.
And you'll also notice if you read that Medicare and You handbook, it talks specifically about that expansion. Thankfully, again, mental health is like becoming less of a stigma and more of like something that we
Yeah.
all accept. Like, hey, everybody deals with something at some point, and
Yep.
mental health is a kind of a crisis
Yeah.
globally, but especially here as we're kind of getting over the stigma. So yeah, there's expansion in medical and mental health providers, mental
Mhm.
health coverage, including moving into 65 plus. So when you're working, you often have, dental and vision coverage. I often call it like more of a discount plan than an insurance
Sure.
plan, just because there's actually caps on coverage
Yeah.
on those plans. But if somebody wants dental or vision, which again are, two of the things that kind of go bad as you age, how might somebody get coverage for dental and vision moving into Medicare?
Yeah, so there's a lot of products and plans out there, and a lot of them are truly, like you said, Cody, they're discount plans. They may pay up to $3,000 for the calendar year, and they're going to cover what they call usual and customary charges, which, similar to Medicare assignment, is this procedure should cost $1,500. We're going to pay your 60% coverage based on that. Well, if your dentist bills over usual and customary, you're
Mm.
seeing a gap and you're having to pay that gap yourself. If someone comes to me and they are interested in it, I'll absolutely talk about it. But the biggest question I have is, what's your anticipated usage or what's your anticipated needs? If I go to the dentist for one cleaning a year and that's about it, it's likely not going to be a good fit for you. My advice would be, call your dentist and ask what the cash pay price of a cleaning is. Usually it's less than $100. If you go twice a year, $200 out of pocket, you're going to pay more than $200 a year in premiums for a dental dental plan, and they may cover that cleaning at 100% because it's preventative care, so it's important, but you're still paying, $300 a year in
Mm.
premiums to use $200 worth of services. Some people are like, that's fine. I want it in case something goes bad. Absolutely, we can get you a coverage. But again, it's gonna have a cap, and it's gonna only pay preset percentages based on usual and customary charges.
And with dental and vision, it's different that there's no penalty to like having it and then not having it. And it's
Yep.
also not something that you have to like lock in when you turn 65.
Right. You can pick one of these up at any point with,
Yeah.
someone could be on Medicare for 3 years, call me and say, I want to get a dental plan starting in April. Okay.
Mm,
We'll put
yeah.
one in. It'll start April 1st for you. If you want to pick it up, maybe you were told, hey, you need glasses, and I may as well just get a bundle plan, something that'll pay for frames and lenses for me, and then it'll cover my cleaning. It's like, absolutely, let's get that taken care of for you. But you can pick one up at any point throughout your Medicare journey.
Maybe a kind of a little sidebar here. Now that we're talking about, paying for, dental, vision,
Mhm.
glasses, contacts, actually paying for the care. We do talk about HSAs. This is a common misconception is that even though you can no longer contribute to an HSA, in the months you're covered by any part
Mhm.
of Medicare, that doesn't mean that you can't spend your HSA on qualified medical expenses. So just keep in mind, whether you knew this or not, just remember that not everybody understands that contributing to an HSA and distributing from an HSA are different conversations.
If you waited 2 years to enroll in Medicare and you've been contributing the entire time, I don't
Mm.
ever want someone to have to deal with those look backs. It's not fun. So, like I said, this is actually something where I usually default to financial planners and financial advisors of this is much more someone else's area of expertise. And I want you to talk to someone that really is an expert in this field. I can cover the basics, but someone like Cody and his team
Mm.
is going to do so much more justice to it than I would on how to advise on these situations.
Yeah, without going too deep here, effectively, if you enroll after 65, there might be backdated coverage for 6 months. And again, backdated coverage also would exclude those months from HSA contributions. So I guess maybe just the light bulb should go off as soon as you hear 65 or Medicare, immediately think HSA, and just be careful. And
Yes.
keep in mind, like it's not too bad to remove excess contributions and things like that from HSAs. Like it's kind of a return on hassle. Is it worth doing it and having to potentially backtrack? HSAs are easy to fix, quote unquote, easier to fix, but there are some hidden costs of Medicare that I would love for you to talk about. Do you want to mention anything else about the Part B or Part D penalties and late enrollment?
Yep. So late enrollment penalties and IRMAAs are two of the biggest hidden costs to Medicare that people don't think about. Those are going to be penalties that if you've gone for the Part D side more than 2 months without credible coverage, credible is always the caveat there. People, how do I know if my plan's credible? You don't. Ask your HR department. They will tell you. You get a notice in the mail every year. I know not everybody keeps them. Ask your HR department. They'll tell you if it's credible. That's the easiest. That's who you need to talk to about it. But it's 63 days without credible coverage. You can start to accrue a penalty. That penalty does not ever leave. Is the thing that there's no way to get a Part D or Part B late enrollment penalty wiped away once it's been set and established that yep, they went without coverage. We're going to assess the penalty. The longer you go, the more that penalty accrues. It is compounding interest in the most negative way possible. It keeps just building on itself every time you don't have coverage. And so it's really important to really minimize those risks because I've seen, $2 penalties a month. Like they can be small or they can be really, really big, especially for individuals that have been eligible for a while and just never had coverage. That can be a really costly penalty. So it's really important when you are approaching any of these windows that we've talked about that you talk to your benefits advisor at your job and then a Medicare insurance agent to make sure, okay, my plan is credible. I'm going to continue working. I'm going to delay B. We're over 20 employees. Can I delay B and delay D without being assessed a penalty? Great. You've covered your bases. You're good to go. It's okay. Or if you come and you say, well, we're under 20, but it's credible for drug coverage. Okay, well, you may need to look at picking up B just to make sure you don't get a
Mm.
Part B late enrollment penalty that will also never leave. But to the IRMAA cost, where it's based on your adjusted gross income from 2 years ago, that is a big hidden cost that higher earners can see. And Cody's got the chart up here based on how those brackets may fall out. Part B IRMAA can get really pricey for individuals on that. But there are what they call life-changing events that you can actually fill out a form, and they will look at that and they will assess that. And so you can see here, if someone is, if your MAGI is 200 to 500,000, you're going to pay over $400 a month for your Part B premium. Like, that is a lot different cost basis than someone that does not have an IRMAA penalty assessed onto their Part B coverage. But if you have a life-changing event, some of the most common ones that I see anyways, things like divorces, unfortunately, or if they have sold their company or sold property. Those are the biggest ones that cause large fluctuations and large spikes that I see from individuals. Work stoppage, death of spouse. There's a lot of different ones. But if you're like, I've had a hunting lodge for 20 years, but now that I'm retiring, or now that I retired a couple of years ago, I actually sold it and it spiked, $500,000 on my income that I'm never going to see again. They take a look at that. They don't want to assess these extra penalties and extra fees that don't really need, in asterisks there, need to be there. But if someone truly is a consistent high earner, expect to pay IRMAA premiums.
And I'm going to add a few little notes here that, let's say somebody's 70 years old, they've been retired for a while. They did like a massive, they do like a significant Roth conversion.
Yeah.
And then 2 years later, they get hit with IRMAA. They're like, oh my gosh, but my income's way lower this year because I didn't do a conversion. You notice that Roth conversion is not on this list, right? A Roth conversion might not make a difference, but only if you have another life-changing event simultaneously. Yeah. So maybe a common thing here, let's say somebody is 65 and then they retire, and then the next year they do a Roth conversion. Right. So like they might actually kind of get that little nice window where they can kind of claim the life-changing event and, kind of cover that Roth conversions potentially simultaneously. But I do want to show just a quick example that this is, again, keep in mind, this is 2024 chart. I got to make a new one for 2025. But really, this shows that Medicare Part B and Part D, this is an individual game, an individual sport, right? Like golf, that, this is a per spouse. And these are, in the chart that I have here, I'll upload these, that this is actually the annual cost, not monthly, thankfully. So this is annual per spouse. These thresholds here are actually cliffs. This is one of those things where if your modified adjusted gross income goes $1 over, you can see here, potentially be paying like another, almost like $900 more per spouse for Part D, plus an additional for Part D. I don't necessarily let IRMAA like wag the dog. Like, I would say that IRMAA will never represent more than 3% of your income as a household. So it's kind of like a nuisance tax in a way. You do need to be careful about maybe potentially going like $1 or $2 over and, pushing yourself into a higher bracket. Keep in mind that these are not announced in advance. So even though these are like 2-year lookbacks, you won't know what these thresholds will be. Most people just say, hey, just maybe base it on like kind of average inflation, let's say 2.5%. But I think it's best conservatively to just kind of assume that, again, this is 2024, but I might just assume the modified adjusted gross income limits for today, for 2 years from now, just to make a conservative assumption. Again, that assumes no inflation, which it will be adjusted by inflation. But just keep in mind that this is something that you can't get perfect because you literally won't know in advance. But I also want to show on SSA 44, when you claim that life-changing event, you have to prove it. So even if you stopped working, you also see here in step 4, there's documentation proving your life-changing event. It's not that complicated. I've also heard of people even calling and filling out an SSA 44 over the phone, which that kind of blew my mind. I didn't know that was possible. But again, just keep in mind that even though you're working with like administrative, again, the ship that moves slowly, there are definitely ways to do this pretty efficiently, especially if you're working alongside a client along the way. One thing that you mentioned to me that I was fascinated by is this idea of cancer coverage.
Yeah.
And this is one of the biggest concerns, Medicare or otherwise, is saying, what if I have some type of cancer that needs maybe even an experimental treatment or just treatment that just simply isn't covered by, original Medicare or even like a supplemental plan? Could you describe like what is that fear of cancer that you hear from people? And also, are there ways to actually get coverage for those potential challenges?
Yep. So what is the fear with, obviously, the cancer diagnosis? One is scary and terrifying to deal with. And the unfortunate reality is that the numbers say that just shy of 1 in 2 men and 1 in 3 women will get a cancer diagnosis at some point in their life. Right?
Wow.
The reality is that the numbers are staggering. And we're actually seeing a lot of increased diagnosis in individuals under 50. Specifically in the under 50 class, it's actually a lot of colon cancer right now. We don't know the cause of it at this exact moment in time, but about 60% of the total cost of cancer diagnosis are actually non-medical. in nature. You talk about experimental treatments. That's never going to be covered by insurance. You're almost never going to get a prior authorization for that. But also there's travel aspect. There's loss of work if, and not just for you, but say I'm diagnosed with cancer and unable to work. My spouse now has to also drive me to appointments because I'm likely not going to feel good after a round of chemo or a round of radiation.
Right.
Someone else also has to take time out to drive me. That may be time off from your
Mm.
spouse's job. Maybe that's your kid taking time off to come drive you to and from appointments. I had a case where someone actually had to stay at an Airbnb because they had to be quarantined because of the type of cancer that they were going through. And chemo rounds is not uncommon for it to be a month or 2 months at a time. I don't know too many people that plan to go stay at an Airbnb for 2 months at a time and can work that into not only then paying for the medical costs. They actually say that the average 6 month cost of like chemotherapy and cancer treatments is $27,000. The
Mm.
last thing that I want to hear from a client, one is you didn't tell me that this was an option, or two, I just had to call Cody and pull out $30,000 from my retirement nest egg to pay for this. Like that's something neither of us want to ever have to hear in a conversation in a discussion. And so cancer coverage is going to be those for not actively going through cancer and or have been in remission for 5 or more years. So it is available to people that have had it in the past, but that are in remission. The way that it works is they will issue coverage, and this can be for an individual and the spouse, or an entire family as
Mm.
well. And I think that's a really important caveat, especially for younger individuals, that your entire family, including your kids, can be covered on one of these policies as well. The way it works is in the event of a diagnosis, you send in your oncologist form with the applicable codes on it, and then they cut you a check within a week. And so benefit ranges are $5,000 all the way up to $75,000. And so let's say, so we have a $50,000 policy on myself, my wife, and our little boy. And so say I get diagnosed. I send in my claim form, the carrier cuts me a check for $50,000. That doesn't mean that that money is not available for everyone else that's also still covered. And so if it's you
Mm.
and your spouse, that's 50,000 per spouse, not total for the policy.
Mm.
And so I think that's a really important caveat too. These plans are very affordable. And I think thinking about how you're going to pay for cancer diagnosis in the event that it may unfortunately happen is a crucial part of any financial planning.
I live down in Houston, Texas, where MD Anderson is known to be one of like the the
Yeah.
top cancer centers, and people travel in from all over the place. And yeah, that's
Mhm.
one of those things. Like it's not in the spreadsheet. Like that idea of like, oh, like what would the cost of like staying in another state for months at a
Yeah.
time in quarantine plus chemo,
Eating
not
out.
feeling well, right? Needed to have food delivered versus like going
Mhm.
grocery shopping. Sometimes we assume, you're going into Medicare age, for example, you're married, your spouse is, you can care for each other. You have your kind of like your physical and mental health are in good place. But think about, the future of, either not being married, not having that support,
Mhm.
being truly independent at some point. That can really become costly, not just financially, but in like think about your energy. You're like your
Mhm.
energy going through this cancer treatment on top of needing care. It can be extremely expensive. So this is not like a fear-based selling
No.
tactic here, but this is just the reality of the things we don't think about. Like the 1 and 2 and 1 and 3, like those stats are scary. Disability insurance is so much more expensive than life insurance. It goes back to that actuarial
Yes.
calculation of if you're a lot more likely to need, to go through this peril or this, this risk. If it's more expensive, it's not necessarily that they're just trying to like, take more money out of your wallet. It's
Yeah.
because it's the true actuarial cost of covering these things. Plus, of course, the insurance companies do make their profit. You do see the names on the the stadiums and the buildings out there. But just keep in mind that insurance is simply a transfer of risk for
Mhm.
perils of low frequency but high financial severity. So insurance in some form will probably be a part of your life, your entire life, not just certain
Yep.
segments. Some people will come to me and say, my income is very low. Most financial planners and advisors, maybe unfortunately, we primarily serve the wealthy, right, who have like the money to manage and things like that. Being advice only, where I work with any client of any asset or income size, I might work with a client with less income. So, could you describe kind of how Medicaid and Medicare, how they're separate and maybe how they can play together?
Yeah, absolutely. So obviously Medicare is a federal agency and a federal entity, but Medicaid is operated at a state by state level. Every state handles it a little bit different. They all have different thresholds. Well, what does that mean to someone that's on Medicare? So when you're on Medicare and you have Medicaid, you're what's called a dual client. You have both. And the way that we see that operating now within about 15 states is they have what are called integrated plans. That's where your managed care organization or your MCO, which is just the entity that handles your Medicaid at the state level, and a Medicare Advantage carrier in that state have a plan that's available for you to enroll in. You can enroll in that, and there's a coordination of care directly between the two entities. If you're in a state that does not have an integration plan option available, you can absolutely still enroll in a dual plan with a Medicare Advantage provider that's in your market. But it's a different level of coordination of care and coordination of benefits. But the integrated model is becoming a lot more popular. And so you need to make sure every year you get a benefits award letter. They'll tell you who your managed care organization is going to be. Make sure you're taking a look at that and make sure as these things change. So do the way you need to look at and the way you need to look at your coverage, because yes, Medicaid is going to pick up the vast majority of your bill, but that doesn't mean you can't still get access to those extra benefits that Cody and I talked about earlier that can be available on Medicare Advantage plans.
A lot of that is like whoosh over my head, but in a good way, a positive way, that don't do this alone and don't make
Mm-hmm.
assumptions.
Yep.
I just find that, again, these are just very complex things that even as financial planners, where we like to go down the rabbit hole and like to go into the deep end of all these topics, like,
Yep.
we don't know what we don't know. Before I even say anything, so Will and I have no professional relationship. He's not paying me. This is not an advertisement or some type of marketing. When people do provide really helpful education to us in the community, I definitely want to just let them talk about, how they serve people, resources, also ways that potentially you could collaborate with Will, with or without clients in the future. So Will, I'd love to learn more about how people can learn more about you, how you
Mm-hmm.
serve clients, and maybe some additional resources that you may have even beyond our conversation today.
Yeah, absolutely. So the additional resources that I have available for clients and for advisors if they ever need it, I have a great chart that will break out, if you need to enroll in a Medicare Supplement or Medicare Advantage, kind of how those ways, what the differences of them are. And then every single year I update a Medicare cost sheet is what I call it. And it's just quite literally, what are the premiums for the year? What are the deductibles? What is the MAGI numbers that applies to the IRMAA when that comes out every year? So every year I go through and I make those types of charts. I'm more than happy. I'm actually going to send them over to Cody whenever we wrap up our conversation here so that he has them and can make them available for all of you guys in the community to access and to grab and to pull whenever. I'm always happy to be pulled into conversations or emails or things like that with people that have questions, even if they already have another agent. It doesn't mean that I can't answer a question for them. So I'm happy to truly be a resource. I'm licensed in Iowa resident, licensed in about 15 states. Can always pick up additional licenses if you do have clients that do truly need some help. More than happy to be a resource in that avenue. But really, I just want to make this as stress-free and as easy for all parties involved. For you guys, as your clients are asking you questions, happy to be a resource just for a financial advisor and just, shoot questions back. People can always text me at my numbers. And so I like to be easy to reach and I like to be easy to work with, but I really just want to be a resource. I find myself to be a resource in the community. I'm here just to answer questions. If you decide you want to work with me, that's awesome. Absolutely love it. But I want this to be as easy and as stress-free for people as possible. My tagline at my agency is be sure, not just insured. And
Mm.
I try to live by that. Like I want someone to
Mm.
be sure in the choices that they're making, not just insured by insurance.
I love that. Well, we appreciate you so much. There's a phrase I use, which is clarity precedes confidence, right? So before somebody can feel confident making that Medicare decision, including the Advantage and the supplemental plans and all the letters, the alphabet soup, they first need to gain clarity on, another phrase I use is we must understand where we are before determining where to go and how to get there. So I love that I can just tell already that you really take a whole like life approach to Medicare coverage. You don't go straight toward the product. You say, tell me about your life. Tell me about your family. To give advice in somebody's best interest, you first have to understand their interest. So again, I like that you can plug the appropriate product into their life rather than trying to plug their life into the product that you're trying to
Mhm.
sell. So I really appreciate you really not letting the product lead the plan. And I can tell that you really do it right. So I appreciate you so much, Will. And I'm excited to have more conversations in the future.
Absolutely. Thank you so much for your time, Cody.